Yes, sir.
Time constant. Yeah.
Yes. Good evening, sir. And good evening, dear friends. I am Dr. Priyadarshini. Presently, I am doing my postdoctoral fellowship in neonatology in Coimbatore, Tamil Nadu. I'll be talking today about time constant. I hope by the end of my presentation, we'll get to know how time constant helps in choosing the safest and effective ventilator setting. Time constant is a single parameter that can tell us about the entire respiratory system. Grossly, it is a measure of how quickly a neonate's lung inflate or deflate. Next slide, please. So, by definition, it is a measure of time expressed in seconds necessary for a step change towards equilibration. So, it is a time taken for alveolar pressure to equilibrate with the proximal airway pressure. One time constant is a measure of time necessary for the alveolar pressure or volume to reach 63% of change in airway pressure or volume. So, one time constant is the time taken for 63% of change, and two time constant is 86, three time constants is 95, and so on to five time constant of 99% change. So, in this time constant curve, the rising curve is the increasing exponential time constant curve, and the down one is decaying exponential time constant curve. In the increasing curve, one time constant is the time taken by inspiratory volume, inspiratory lung pressure, or expiratory flow to reach 63% of steady state value. Similarly, in the decaying curve, one time constant is the time taken by expiratory volume, expiratory lung pressure, or inspiratory flow to decrease by 63% so that it reaches the 36% of steady state value. Next slide, please, ma'am.
Yeah, we'll just stop here. Go back to the slide there.
Yes, sir.
I hope everybody has understood basic concept of time constant. Can anybody else explain, or if there is a confusion in anybody's mind, can somebody raise their hand or unmute themselves and tell me?
Sir, excuse me for a while, sir. I think Ma'am Jyoti is sharing my previous presentation, the corrected one.
Doesn't matter, Priya. Doesn't matter. Even this presentation is good. Don't worry about it.
Okay, sir.
So, can somebody come online and say, have they understood time concept?
It's time constant. Three time constant is needed to 95% inflation or deflation of lung. That's
okay.
On which we can decide about the I time. Long.
See, in fundamental principle, what I am trying to tell is, you are giving, let's say, oxygen and air mixture into a baby's lungs. Okay. Now, this is, let's say, the proximal airway. This air and oxygen has to go all around into every part of the lung and come back. This time taken is called time constant. If you understood that, so that if at the tracheal level, what we call the proximal airway, the input and then the output comes back from the lung is equivalent. It becomes equivalent. That means how much you have given has entirely come back. That entire thing is the full time constant. So, one time constant usually is able to cover 67 or maybe about 63 to 67% of the baby's lungs. Two time constants can increase this component to about 86%. But if you do it about 5 times, this time is spent, that covers almost 100% of the volume of air and oxygen you have given comes back. So that at the most distant alveolus in every part of the lung, the oxygenation is the same as what it is there in the proximal alveolus. You understand how much time it takes for the air-oxygen mixture to go and come back? That is, it's like doing a circuit and coming back, and how long time it takes. Have you all understood this?
Yes, sir. Sir.
Okay. Then yes, we'll go ahead with the next slide by Priya.
So, time constant, by calculation, it's a product of compliance and resistance. So, factors affecting time constant will be any factor which decreases compliance and decreases resistance will decrease time constant. And the factors which increase compliance and increase resistance will have longer time constant. So, for example, RDS is a condition with low compliance where we will have short time constant. So, air will move in and out of the lungs very fast. And BPD is a condition with high resistance, like where we have longer time constant. Next slide, please, ma'am. So this is a picture, like the first one is a normal airway and alveoli. Second one is an alveoli with low compliance and low resistance airway. Third one is high resistance and high compliant alveoli. So low resistance and low compliant alveoli will have shorter time constant. High resistance airway and highly compliant alveoli will have longer time constants. So far we have seen time constant is the product of compliance and resistance. Let's move on to an example of how to calculate time constant. This neonate lung has compliance of 3 ml per centimeter of water and resistance of 30 centimeter of water per liter per second. So time constant is product of compliance and resistance. So 3 ml we are converting to liter, which is 0.003 liter, and the resistance of 30 centimeter water per liter per second. So one time constant here will be 0.09 second. Next slide, ma'am. So for complete inspiration or expiration to occur, inspiratory time and expiratory time should be equivalent to 3 to 5 time constant. So from looking back from the previous example, we have calculated one time constant as 0.09 seconds. So for the appropriate TA and TA should be somewhere between 3 time constant to 5 time constant, which is 3 into 0.09, which is like 0.27 second to 0.45 seconds. So TA and TA anywhere between 0.27 to 0.45 seconds will lead on to complete inspiration and expiration in this baby. Next slide, ma'am. So when TA and TA is not set appropriately and when TA is too short, what will happen? So when TA is too short, there is incomplete inspiration, which will produce low tidal volume and which result in hypercapnia. Incomplete inspiration will also decrease mean airway pressure, resulting in hypoxemia. Next slide. When TA is too short, there is incomplete expiration. So there is air getting trapped in the lungs, which will decrease the compliance of the lungs, resulting in hypercapnia. The air trapping will also increase mean airway pressure, decreasing the cardiac output. So clinical implications of time constant. So any babies with short time constant, they ventilate well by decreasing the TI and TE and increasing the rates. And babies with longer time constant, they ventilate better by increasing TI and E and decreasing the rates. This is actually Sir pointed out with the previous presentation, where the baby with RDS, they will have shorter time constant. So they will be ventilating better with the shorter TI and TE and increasing the rates. I'm actually, prepared presentation with ventilator waveforms on how to adjust TA and TE.
Now we'll change over to that. Jyoti, can you share the newer presentation of what Priya had sent?
1 second, sir. This is the slide I have. I'll check once more. Please give me some time.
So what happens, as now we understood, the air goes into the alveolus, but if there's a resistance, the alveolus will take a longer time for it to be expelled out. So therefore, it increases the time. So if you even keep a short I time and a longer expiratory time, still the time constant will be long. Now, you may have seen one of the videos which was made and shown by Dr. Razak in his presentation. There are two balloons. One is a small balloon, both these balloon sizes are same. Both of them are connected to syringes. One is a 2 ml syringe and one is a 20 ml syringe. So just think that the 20 ml syringe is a large baby with a large lung with no obstruction. Air goes in, comes out, goes in, comes out without any resistance or obstruction. So that large balloon, if you fill it to the same amount of air as a 2 cc syringe, it will expel out all the air very fast. Now the 2 cc syringe, you connect it to the same amount of air, it gets enlarged, but the air is now coming out to a narrower gap because the small size of the orifice is there. Therefore, the resistance of the expelled air is high. So as a result, the time taken for it to become out is faster, is going to be longer. So these are the situations you have to think. Now just think, as a lung which is very stiff with severe RDS. So as a result, the alveoli are actually closed. It's mostly the lung is ventilating in certain areas. So, in severe RDS, what happens is there are some areas which are well ventilated but poorly perfused, or the reverse is happening. So, there's a lot of ventilation perfusion mismatching which happens in severe neonatal RDS. So, sometimes if the alveolus is open, the air goes in fast and comes out fast. But in certain areas, the alveolus is absolutely closed. It doesn't allow the air to come in. So, there also the air comes out fast. But typically, because of the stiff lung and the tight lungs, the time constant is very short in severely RDS babies. So, therefore, you need to give smaller inspiratory times in severe RDS. Now, on the other hand, if you have a baby who has got severe chronic lung disease, or what you call bronchopulmonary dysplasia, the resistance to even pushing the air in is very high. So, it takes a longer time for that air to go in, get gas, do the gas exchange and come out. So, it takes longer. So, chronic lung disease or BPD, you need a larger eye time. So, these are the principles you learn as you grow into the course more. So, let us have Priya now explaining about this flow volume which you wanted to show.
So let's see with the help of ventilator waveforms how we can set the appropriate TA and TE. This is a normal flow time scalar where flow is along y-axis and time along x-axis. The curve above the baseline is inspiratory flow curve and the curve below the baseline is expiratory flow curve, where phase 1 is the pressurization of respiratory system carried out by ventilatory system. Phase 2 depends upon the compliance and resistance of lung. And phase 3 is passive elastic recoil and passive expiration. Phase 4 is active expiration, which can be moderated by prolonging the expiratory time. So in this flow time scalar, we can see the inspiratory flow curve not touching the baseline before the beginning of expiration. So this means the set TA is too short. So when TA is too short, airflow is not completely delivered to the lungs. In this case, increasing the inspiratory time allows for complete inspiration. So in this, the inspiratory flow curve touches the baseline followed by a pause and the beginning of expiration. So this means TA is too long. There is timing in the ventilatory cycle that is not used and which may be necessary for complete expiration to happen, especially when we are using high ventilatory frequency setting. So in this case, it is enough to decrease the TI so that expiration starts immediately at the end of inspiration. So in this scalar, the inspiratory flow curve that does not touch the baseline before the beginning of next breath. This means TE is too short, so air is not completely expelled from the lungs, resulting in gas trapping, which is auto-PEEP, which increases the risk of pulmonary hyperinflation. In this case, increasing the TE will allow the airflow to completely exit from the lungs. So it is a ventilator waveform showing auto-PEEP and its effect. In pressure time scalar, we can see there is a progressive increase in end expiratory alveolar pressure creating auto-PEEP, which in flow time scalar, the expiratory flow is still occurring at the beginning of next breath, resulting in air trapping, which progressively increases the end expiratory volume in volume time scalar, resulting in dynamic hyperinflation. So among loops, flow volume loop demonstrates air trapping better. So this is normal flow volume loop where the inspiratory flow curve reaches tidal volume and then begins expiration, which reaches the FRC point and then inspiration begins again. So in case of air trapping, we could see expiratory curve not touching the baseline before the beginning of inspiratory arm. So which means there is air getting trapped. So flow time scalar and flow volume loops are the best ones to look for air trapping in ventilator waveforms. So this is a normal time constant value in normal newborn and RDS and BPD. So normal newborn will have time constant between 0.09 to 0.15 seconds. As I explained already, RDS is a condition with decreased compliance. So they have shorter time constant of 0.05 second. And BPD is a condition with increased resistance. So they have longer time constant of more than 0.15 seconds.
Thank you. Yeah, that was very good. I hope it was well understood by the by the trainees here. Is anybody still confused about this? Can somebody raise their hand or unmute themselves?
Here, I want to go back to that slide where there were 3 loops, and it was showing. Yeah. There's a slide. Can you please explain it? Okay.
Yes, ma'am. The first one is pressure time scalar, second one is flow time, and third one is volume time scalar. So in pressure time scalar, we could see the solid lines or the set peak, and the discontinuous lines or the peak, like which is like getting accumulated because of auto peak, which is like getting increased by the effect of auto peak. And in flow time scalar, we could see the expiratory arm not touching the baseline before the beginning of inspiratory curve, which means that there is air getting trapped with the expiratory breath, which is not expired before the beginning of inspiratory curve. And in volume time scalar, with the effect of auto peak, there is progressive increase in the end expiratory volume in the lungs, which is producing pulmonary overinflation.
So essentially, Kanksha, what she said is, and over a period of time, all this air which is trapped inside the alveoli is slowly increasing the pressure in the alveoli, and naturally the volume itself is not getting emptied faster. So therefore, there is progressively increased auto peak. So you may think that the peak you are delivering is 6, but actually the child may be getting 10. So the chance of lung injury becomes high, chance of ventilation-induced lung injury is higher, and also air leak syndromes, including in small babies, pulmonary interstitial emphysema, all that can occur. You have to be a little careful to avoid auto peak. That's the reason why we were discussing this. So inspiratory time is very important to set correct. So most of the times you will not go wrong if you keep the inspiratory time about 0.3 to 0.35 seconds for 3 terms with RDS. Later, of course, we'll be discussing other modalities like disease-specific ventilation like meconium, etc. But we'll restrict it to RDS and BPD here. In BPD, you can give larger I times, maybe even up to 0.6 to 0.8, because you want the air to go in and fill in the lungs. There's a lot of resistance for the air to go in. Whereas the resistance is no doubt high in RDS, but the compliance is also very high, very poor, as a result of which the time constant becomes less. So you need to give short I times. You don't want to give long I times, and you want to give longer expiratory time for the air to come out so that auto peak is not generated. So this is the fundamental concept. Marcia has a question. Marcia, please unmute yourself and tell me.
All right. Thank you for the presentation. It was very good. Just to ask, are there some ventilators that will actually show you the value of the compliance and the resistance, or you have to sort of calculate? I'm just thinking of, sometimes we have those very difficult patients. We are failing with BPD and you're failing to get good SATs. Are there ventilators which actually show you the compliance and the resistance so that you can sort of itemize or calculate the I time for that specific individual, or you have to?
There are new ventilators which tell you all these graphics, so you can adjust based on the PV loops, especially. You can adjust whatever values you want to. And in fact, these ventilatory waveforms also, this has been taken from the screen of ventilators like this. You can even get levels of the compliance and the dynamic compliance and C20 levels easily shown on the ventilator screens. So it's become very modern, like using modern new cars. The fundamental principles of ventilation are like fundamentally knowing how to drive a car. But all these added benefits are there in newer ventilators which can help you do it better. So we will be discussing it, especially in the personal contact session. The ventilators and actual demonstration of all these things will be much more clearly defined. So fundamentally, you will not go wrong. If you have an antiquated old ventilator like this pressure-controlled pressure and time cycle ventilator, which is the demonstrated case which you discussed earlier, you keep the I time 0.3 to 0.35, keep the PIP according to what the chest rise is showing, and make sure the peak which you set is not more than 5 to 6 centimeters water, FiO2 according to the child's need. Make sure the map which you calculate, which you either calculate by the formula or you calculate it from the machine. MAP is a measurement which most machines will give you. Make sure the MAP is not very high, maybe to start with about 10 to 12 centimeters H2O, and then you can decide to increase or decrease based on the blood gases and the X-rays. So I think this is the fundamental principle of time constant, which Priya has nicely elucidated. And anything else? So what happens, Priyadarshini, that if you increase the eye time too much, or let's say the opposite side, if you have a very low eye time, what can happen? I think you mentioned that low eye time can cause hypoxia. And if you increase the eye time too much, what can happen?
Sir, it will again, when we increase the eye time, so we are actually decreasing the expiratory time, so which will result in air trapping, sir.
So therefore, the chances of lung injury, air trapping, and also air leak syndromes become very high. So you have to be a little careful. So any other questions, anybody? Any other comments by anybody else, please? Okay, so shall we today then call it a day, or do you think is there anything else? Somebody went through these two modules and the 6 lectures. Any questions on any of them, please? Any questions?
Sir, I have a question regarding caffeine.
Yeah.
Should we start in each and every child less than 32 week? Say child is around 31 week, 1.3 or 1.4 kg.
Fine. Any child with RDS who was gestating less than 32. Suppose that the baby who's, let's say, 32 weeks and there's nothing, that child, unless the baby gets apnea, you don't have to do it.
Okay.
But anyway, we discuss this in the caffeine discussions when we do that. The modules will come up. Any other questions on the, pulmonary dynamics and also the golden hour and all we've discussed, I think seen 6 videos till now. Anything else on the videos? Great. Then any other things on the time constant and resistance and compliance which you want to discuss about, which we discussed about today?